My mom's like, why hasn't this been changed? It needs to be changed every day. My grandfather, he was in the cold in the army, so we got an ulcer on the bottom of his foot because the facility wasn't taking care of it, and it ate from the toe all the way up his leg.
Oh my gosh.
And the dressing wasn't changed for 2 days. My mom went in there and because she's an RN.
Yeah.
You know how you're talking about like the wrinkles in the bed? Like my aunt got these like massive like wounds and like open wounds from like her bed not being like fully like because the hospital nurse wouldn't like make it fully. I guess so. I flipped my aunt over one day to like change her clothes and like I just see all these marks. I was like, I really started kind of like, this is. And then I called the nurse. She's like, oh, don't worry about it. It's just I said, don't worry about it. There's blood on the bed. I was
Oh
like,
my
"There's blood
gosh.
on the shirt." There was like gashes all down her back. I was like, "Oh, don't worry about it." I was like, I could get infected so easily. I was like, I could
Sure.
get more sick. I'm like, goodbye.
Yeah. So that tells me two things. Number one, the position wasn't changed often. So she was laying in one position for a prolonged period of time.
I like made her like move over. I was like, at least you could do is move over.
Yeah.
Move over a little bit, get in a different position. Yeah.
Yeah, use some pillows or yeah.
One of those beds from like I don't know where we got it from, but it lifted up. I did all that all the time.
Yeah.
There's nothing much you could do. She was going pretty fast, like a pretty fast pace.
Yeah. And unfortunately, you know, during the dying process, let me just make sure. Yeah. Okay. It does look like oops, I got somebody joining. During the dying process, just like, you know, we've talked about, no. Okay. We've talked a lot about, how each part of your body is like a factory that does its own thing and then the whole thing works together, right? So like your brain is a memory making factory. Well, just like those factories age, during the dying process, all of those factories are shutting down little by little. So skin is one of those things that gets affected pretty quickly. It's kind of like the canary in the coal mine type thing, because as the heart doesn't pump enough blood around, the skin isn't going to get good blood flow. So we end up with ulcers and sores and things like that. But we also don't take in as much protein. Now, protein is important to keep muscles from breaking down. If you don't have enough protein, your body will actually break down muscle to compensate. So if we're at the end of our life and we're not really eating real well, and protein is usually not something that tastes good at the end of life. So the skin really starts to show the effects of the dying process. So in that respect, the hospice nurse was not wrong. Okay. But the way that she explained it was, that's not oh, don't worry about that. That's not how we handle it. Explaining to the family, I'm so sorry. And I know that's very distressing to see, but she is more comfortable in this position. So we really can't move her a whole lot. So she's going to have skin issues because she's not moving. She doesn't have good protein intake. And, you know, the body isn't circulating good blood to her skin. So although it's upsetting, this is probably an expected event. Let's see what we can do to make her more comfortable with these parameters. Now, if it had been explained like that, that's a totally different situation than, oh, don't worry about it. Right. Yeah, all you're seeing is blood and yeah. Oh, that would be, yeah. Oh, that would be terrifying.
She was sitting there crying. She was like,
Oh,
I don't know what to do. I don't know what to do.
yeah, no, they should never have left you with an unanswered question. That's unfortunate, and I'm very sorry for that. I was a case manager, a hospice case manager for 5 years. So I can tell you with absolute certainty that that's not the right way to handle that.
So you know how hospice will take certain medications away,
Hmm.
the closer they get to death, what and where. But my twin sister thought that I took the mom's medication away, that's why she got. She thinks that I have heart surgery.
Oh my gosh.
She didn't know what hospice was. I just thought everybody what it was. But to this day, we haven't spoken since April. Yeah.
Oh my gosh.
My dad insisted my aunt because my grandma passed and like they were like in such a deep rooted argument about God knows what. And they couldn't put it like past themselves. And that's what I was trying to, I was like, why should you go to act that way? Because what if something happens?
Yeah, death is either a unifying event or a dividing event. It's, yeah, families will usually react in one of two ways. And this is why it's so important for anybody that's involved in, a dying process, whether it's a CNA or a nurse or a chaplain or a social worker or whoever, to really help the family understand, all of the family understand what's happening. 90% of my job as a hospice nurse was ministering to the family, not the patient. Caring for a dying patient is not difficult. We have a care plan that we follow, we look for symptoms. We try to take care of the symptoms before they become a problem. So caring for the dying individual is really, I won't say easy, but it's not overly complex. There's only so many things that's going to happen, and we know how to handle all of them. It's caring for the family and getting them to understand what's happening and what we can intervene with and what we can't, and getting them to that, if not acceptance, sometimes we can't get them to acceptance, we can at least get them to knowledge. And that really was the hardest part of my job with hospice, is not working with the patient, it was working with the families. Yeah. So let me tell you the worst hospice experience. This actually happened the weekend I quit. So thankfully I had already put my notice in, because this would have caused that in a heartbeat. So we had a CNA home health aide that was working for hospice, who honestly had she should not have been working for hospice. She really didn't understand the philosophy. She didn't understand the processes. She just thought that she was going to go in and do things her way. So she was with this patient, and there's a whole extended family living in the house. So it's the grandmother who is passing away, and then the grandfather who has dementia and's not really aware of what's happening, but keeps asking for his wife. And then you've got a adult child and their children all living in the house. Okay. So it's a multi-generational house, but there are 2 teenagers in the home, and this is prom time. Okay. So this is, there's a lot of stuff going on in the house, and I get a phone call, because I was on call that weekend. I get a phone call that so-and-so has died. We need you to go to the house and, take care of the death event. Okay. So I go, and when I drive up, the fire truck is there. The ambulance is there. There's somebody on the front porch crying hysterically. So I obviously think it's got to be a family member, right? No, it was the CNA that was crying on the porch because when she put the patient on the bedpan, that's when the patient expired. And she didn't know how to handle that. And so she's out on the front porch just hysterical. And now I'm like, well, what's going on inside the house if you are supposed to be the calm one? And why is 911 here? I mean, that's not what's supposed to happen. No. So I go in and it was the worst death experience I had ever attended. The husband, because he had dementia, did not understand what was happening and is trying actively to prevent these men in his home from touching his wife and getting very physical with the altercation. And the adult child is screaming, you know, mom, mom, mom. And 911 is, what are they're going to do CPR. I mean, that's what you called them. You obviously want CPR, so that they're trying to, in the middle of all this. Well, the two teenagers that were in the house were out back. I could hear the screams because it was just such a emotionally charged situation, and they had no support. They had none. They're trying to cope with this on their own. And the girl, the teenage girl, had been getting ready for prom when all of this happened. So I mean, it just was like, I mean, pick a fire. I can't handle all of them at one time. I've got to pick a fire to put out. So the first thing I did was send the CNA away. I don't need you here. You need to go to I will be at the office later. We will talk about this, but you do not need to be here now. Go get her out, because I don't need that additional stimuli. So I get in and I'm telling 911, this patient is a DNR. This is an expected event. They're under hospice care. Please cease all life-saving measures. So I finally got them, but they have a whole once they start CPR, they can't just take my word for it. They've got a whole process they have to go through. So this is continuing for several minutes. And, you know, I mean, she was in stage. You might be able to, you know, do CPR. You're not going to fix what killed her. I mean, it's, you know, that's something that's not fixable. That's why she's on hospice. It's not fixable. It was just, CPR is a very traumatic thing. Life-saving measures is a very traumatic thing. And that's, if we can't fix the problem, doing CPR is traumatic for no reason. So trying to get the family to understand this, and it just was very frustrating for me because it was clear that this family had not been prepared for what happened. The only person from hospice that was there was totally ineffective. So my question was, why didn't the nurse that had been caring for this patient and the family prepare them for this? I mean, why did I walk into this bomb that just went off? And it made me physically ill. And thankfully I'd already put my notice in, but hospice had changed in the time that I was there. The focus had shifted from total care of the patient and family, no matter what, to see as many patients as you can because we're short-staffed. And that's what prompted me to leave. I just could not deal with those situations anymore because I really didn't feel like hospice was doing what it was intended to do. You know, now we're operating like a home health company, you know, and that's, oh, I'm sure. I am sure that it affected that. Oh yeah, yeah. You know, and prom is the one event that you look forward to, you know, get your hair and your nails done, your dress, and no, I'm sure, absolutely sure. So, you know, and that may seem like a very minor thing, you know, when your grandmother that you live with has died, you know, that you miss prom, that seems minor, but it is a developmental milestone. So, you know, somebody's got to recognize that developmental milestone is going to impact that child. So the first thing that I did was we had a children's program director, a grief counselor that works specifically with children. Yeah, that they are awesome. And I called I called her right away and said, I got 2 hysterical teenagers here. One of them, it's definitely a trauma event. You need to be here like 20 minutes ago. Get here. And I mean, she didn't work weekends, but she came that day. But it just was needless. It was totally needless. And had that, and what frustrated me was that this whole thing was prompted by the CNA. It could 100%. So, you know, if the CNA put the patient on a bedpan and the patient expired, well, we understand that happens. So let's make the phone call to the office and let them know to get a nurse here. Let's keep the patient as natural looking as possible, clean them up, let the family come and visit, but most of all, remain that calm, reassuring presence.
Yeah, but sometimes your emotions kick in too.
Yeah, and that's that. She didn't know. I mean, she just panicked, didn't know what to do. What do you do when you're in an emergency situation? You call 911. If you don't know what to do, you get somebody.
When you call 911 or something like that, I mean, you're really not, you really shouldn't. I mean, it's something you call 911 for, but do they ask if the patient is DNR? Or do they just go in there and start doing?
No, they you called for help.
So they just.
Now, sometimes on occasion, you know, if you've got a family member standing there saying she's a DNR, I'm not sure why so-and-so called, you know, because the DNR is always in the folder in the home. So they will, or on the fridge. Yeah. Yep. So they will verify that.
Oh, yeah.
Yeah.
Mhm.
That's, well, that's a bit of a legal gray area. Because it really kind of depends on who's doing the CPR and why. So there's some gray area to that. And I'll give you a couple scenarios to explain this. Let's say that after class, I go over to Walmart and some guy who has terminal cancer, but is still up and walking around and shopping, you know, he's not like deathbed, right? But he's in the pickle aisle at Walmart and he suddenly has a heart attack and drops to the floor and I see it. I have no reasonable expectation to know that he has a DNR, right? So I'm going to, as a good Samaritan, jump in there and do what I need to do because I have no idea who he is, what his life circumstances are. Would I be sued for that even though he has a DNR? No, absolutely not. Absolutely not, because there's no reasonable expectation. Now, let's make this a little bit more complex because this is all healthcare ethics, okay? And healthcare ethics is not cut and dried. So that's a pretty clear indication. There's no way for me to know. I'm not going to get sued for that. I'm a good Samaritan, right? So let's make this a little more complex. Let's say we're working in a nursing home and we have a patient who has a DNR. We know they have a DNR. It is on file. but the patient isn't actively dying, right? They have a condition that will expected to result in death, but they're not dying today. And they're in the dining room and they choke on a piece of steak. Now they're actively choking. Do you do the Heimlich?
Yeah.
They have a DNR. Do you do the Heimlich?
I mean, yeah, because it's something that it's not like naturally happening. With their condition.
Okay. All right. Then that is the correct answer. So this is not what is expected to cause the patient's death. Therefore, the DNR has no bearing on it. DNR does not mean let them die of anything. DNR simply means that I have a condition that I know is going to result in my death. It is not fixable. I can't prevent that death from happening. Therefore, when I die, don't bother trying to do CPR and give me medications to get my heart started again, because the thing that's killing me is still there and it's still going to kill me. And now I get to die twice. That is not something that anybody really should have to go through, right? But if you are having an emergency situation that is causing your death that was not expected, that can be treated, then yes, CPR is indicated. So we have to understand, first of all, that CPR is not a magic reset button. You don't get to respawn with full life. That's the first thing that we have to understand about CPR. The second thing we have to understand about CPR is CPR does not bring people back, ever. CPR circulates blood. That's it. That is it. That is all CPR does. You are being the heart. You are pushing down to push blood throughout the body. That does not bring people back. Does not. Well, you're separating the cartilage. It's not really a bone that you're breaking. It's cartilage, kind of like your nose. But that doesn't like bring people back. All we're trying to do is buy some time so that people can come with medications and defibrillators to correct the underlying problem that's caused the heart to stop beating. But CPR itself does not bring anybody back. The only time CPR, you can see a CPR work is in a drowning case. But again, you're not really, CPR isn't bringing them back. That action of pushing down on the chest is actually pushing water out of the lungs. So, it allows it allows the airway to operate again and breathing to start again. That's the only time that when you're pushing on somebody's chest, they might go, oh, thank you, I'm back. Anything else, when you're doing CPR, all you're doing is buying time for people to come with meds and a defib. That's what may have an effect. Although, it doesn't buy you as much time as you would think. But it also, the ACLS part, the meds and the defib, that may not be as effective as you would think either, right? So we're going to give them every chance we can because, that's a good thing to do. But we have to have realistic expectations of the outcome as well. But so the thing to understand about DNRs is that number one, they only go into effect after the expected death event. So a DNR does not impact treatment at all, ever. It just tells me what to do when the patient dies of what I know they're going to die of. That's it. It's a care plan for after death. It just tells me CPR yes, CPR no. That's it. So we have to understand that DNR, what it does and what it doesn't do. Now, one of the things that that I want to discuss about DNR, and like I said, this is where what you said is a really gray area. In healthcare ethics, there's no right or wrong situation, right or wrong, it's ethics. But remember that DNRs do not affect treatment. So let's say that we have a patient who has a DNR and the patient dies and the family wants CPR done. DNR says no CPR. The family who is standing there says yes. See, this is where it gets tricky, right? This is where you have shades of gray. So in your mind, if you're thinking, well, if I do CPR, I'm going to get sued. Doesn't matter. If a family member is asking you to do CPR, that DNR means nothing.
Interesting.
Now, my goal,
Because they're already suffering too enough. Like my aunt, when she was dying of cancer, she was like, every 5 seconds, she would be like, kill me now. I'd be like, no, ma'am. And then when she did die, it just looks like she was so empty, just like, you don't want me to.
Because I would think if my mom's wanted to be a DNR, and if I just say, well, no, do CPR, then I'm gonna do CPR.
okay, but that's going against your mom's wishes.
No, but still.
So that's where it gets tricky, right? That's where it gets tricky, right? Mom didn't want CPR because mom knew she was dying. There's nothing you can do about what she, about her dying. And if you do CPR and we give her meds and her heart starts beating again, she gets to die again. Right? So, so did we really help? Probably not. So here's the thing, and this is where hospice is so important, because remember I said death is either a dividing event or a unifying event, right? You'll have situations all the time where you have a DNR in place, and then you've got a family member who cannot accept and that's fine. I mean, there's things I can accept and there's things I can't, right? So I get it. Now, my goal here is to get that person to understand why CPR is not going to be effective. I'll do CPR if you want me to, but all it's going to do is cause trauma, and it's not going to bring her back the way you want it to. She still has cancer. That cancer is still killing her. So if we do CPR and circulate blood, that just means that she gets to do this all again tomorrow. So if you want me to do CPR, I will. But it's going to cause trauma and it's not going to solve the problem. So if I can explain it that way, that family member is much less likely to say, do CPR. But if they insist, I don't want them to feel like I killed the patient. And that's what they're going to take away from this. She's dead. You know how to fix this and didn't do it. So is that the impression of medicine that we want to leave with this individual? So if I've got somebody screaming, do CPR, don't let mom die, and I see the DNR on the refrigerator, and I have that conversation with the individual, I'll do CPR if you want me to, but you need to understand this does not fix what killed her. You need to understand that. Right now you have high emotions. But if you want me to, I will. I will absolutely override a DNR. Absolutely. No doubt about it. Because at the end of the day, it's not the patient that's going to sue me. If I'm afraid of litigation, then I need to be afraid of the people that are going to be living after this is all over. Okay. So what you heard is not necessarily true. Now, where it is true, okay, is a wanton disregard for a doctor's order. So if you're in a nursing home and the patient has a DNR and you know the patient has a DNR and the patient dies and there's nobody there, I mean, other than you and the nurse, and you tell the nurse, hey, the patient died, but I'm not okay with that. So I am going to decide to do CPR. Now you have blatantly disregarded a doctor's order. Okay. So like I said, there's a lot of shades of gray there. It's not a cut and dried. And this is, I've heard that from CPR instructors before, but it's not, it may be true in some circumstances, but it's not the complete picture. And if we're going to talk about it, I really think we should be talking about the complete picture, not just one statement. Like, for instance, people a couple of years ago were having DNR tattooed on them. You know, like just, I've decided there's nothing wrong with me. I'm perfectly healthy. I'm fine. I just don't really want people to do CPR on me that for whatever reason. That has no bearing on anything. Nothing. I mean, I don't know if that's the initials of your middle child. I don't know. Yeah, I mean, that I don't care. I'm doing CPR, you know, I mean, because that tattoo has no bearing on me, right? Remember that the only way to get a DNR is to have an expected death event in the near future. We know you're dying. We can't fix that. We can't stop it. It's going to happen in the near future. Near, like within 6 months. Okay, if I ended up with Alzheimer's today, it's not going to kill me for probably 20 years. I don't get a DNR today because I've got Alzheimer's. That death event has to be expected within 6 months. So in 19 years and 6 months from now, I could get a DNR, but I'm not getting it today. Does that make sense? Right? So it is an expected death event from a known condition that we cannot treat. So you got to jump through a whole lot of hoops to get that DNR. I mean, this is not like, I can't call up my doc and say, yeah, I'm just not real thrilled with the whole CPR thing. So can you give me one of those yellow papers, please? They're going to say, no, absolutely not. Absolutely not. Now, if you want to protect yourself, then what you do is designate a power of attorney. So if I know, okay, listen, I know the success rate of CPR is pretty slim. I know most people don't do it right. And I just don't really want to go through all that. You know, as a medical professional, I know all this. So I don't want CPR. Well, if I'm laying on the ground needing CPR, I certainly can't tell anybody that. But I could designate my husband as my power of attorney, and he could then make that decision for me. Okay. Does that make sense? The problem is that nobody's going to listen to him. No. No. And that's okay. Because at the end of the day, I'd probably rather, even though I don't like CPR, I don't think it's effective. Most people don't do it right. But I'd rather take my chances and then let him make the decision to terminate life-saving measures once we know what we're dealing with. But at the CPR stage, you don't know what you're dealing with. You have no idea. There's no tests. There's no nothing. I mean, you've got a body at your feet. I mean, what are you going to do with it? So we got to buy a little time. That's why, even though he might be standing there saying, you know, she didn't want CPR. She did not want this. Nobody's going to listen to him. Okay. Make sense? Okay. Kind of a segue that unexpected lecture, but I think it's important. I think it's important that we understand. Yeah. The best thing that you can do in an emergency situation when CPR is indicated is don't worry about whether there's a DNR or not. Okay, don't worry about that. If you can see it, that's fine. If you know it's there, you can ask the nurse, you know, what do you want me to do when the death occurs? She'll probably say, just come get me. But don't get too wrapped up in whether there's a DNR or not. Do what you need to do. If you got a family member sitting there screaming at you to do CPR, do it. Do it. Because you don't want to leave that. Can you imagine? Can you imagine for a second? Let's just say that you know, are on the ground and I just stand there and everybody, all of you guys are watching me, right? Because I'm the medical professional. I should know what to do here. And I just like looking at you, poking you with my toe and okay. So let's go on with our lecture now. Yeah, I'm just going to let her lay there. I mean, yeah, can you imagine?
Put me out of my misery.
I think she said something about a DNR sometime. So no, we're just going to leave her. Yeah,
I've
well,
seen her tattoo.
yeah, exactly. We're just gonna,
Which
you know.
one I've got too.
So, you know, you don't want to leave that impression with some. We're supposed to know what to do in an emergency. That's like why we are what we are, right? We're supposed to be the ones that know. If you don't know, if you don't act, that's going to leave a very bad impression with people. Does that make sense? So do CPR. Just do it. Unless the nurse has told you or you know for sure. And in that case, you better remain calm. You better, if you're going to panic, then you need to be doing CPR.
Yeah, I'm a panic.
Yeah, if you're going to panic, you need to be doing CPR. Because, I mean, honestly, you don't want to be panicking and not doing anything. That is not, that is just not the impression you want to leave that family with.
Extra minute brings somebody back.
Yeah.
I'll fuck my hand with you shaking.
But remember that we're not talking about a sudden event here, right? We're talking about an expected death event. So you have to kind of get your head in the right headspace here, right? This patient, so how many weeks have you been looking at this lady over here, right? She hadn't moved.
Like 6 weeks.
That's fine.
Yeah, she doesn't say a lot, right? She is like, she's waiting to die. Yeah, she might be. And we're not going to do anything about it other than let a nurse know. Right? So we know she's dying. That we're just kind of walking in to see. You still here? You still breathing? All right. Okay, you still here? Really?
I know what I do. The first female with him and stuff, but I kind of she's sleeping. I just like poke her over.
Yeah, death watch. Yes.
Are you still here?
Yeah, and that's we know it's happening. We know it's coming. It's slow, it's steady, it's a progressive decline. You know it's coming. So all a DNR is telling us is when you know it's coming and it finally comes, don't do anything. Just let the nurse know. We'll do some postmortem care, clean them up, make them look and smell good. That way the families can say their goodbyes. We know it's, I'm not talking about a guy who drops in the pickle aisle at Walmart. I mean, that's a different situation altogether. So in that, yeah, I'd be shaken and panicky, you know, I mean, yeah, because it's sudden. Now I got to do something here, right? So remember that expected death events are the only ones that get DNRs. And you've been watching it. You've been watching it. Waiting. In fact, we have some old nurses tricks that we'll use. Like if you tie a knot in at the end of the bed sheet before you go off shift at night, for some reason, They don't die overnight. Yep. It doesn't always work, but it's funny because you will see some old nurses like me, you will see some superstitious behavior. Absolutely. Back when hospitals had windows that would open and nursing homes had windows that would open in patients' room, you don't see that much anymore. But when a patient did die, the window would get opened because that soul has to have an ability to leave. Yeah.
That's what I do. Like, with my aunt, she passed away, like, in her own home,
Yep.
so, like, I opened the window.
Yes.
And everybody was in-
Yeah. That's exactly right. So yeah, you'll see a lot of superstitious behavior with old nurses. Yeah. Old nurses.
What if the some, like my aunt died in the house, and my other aunt, they live together, but she still sees her in the same house, and she's been dead for years. She see her in the kitchen, you see her in the bathroom, like,
she's visiting, she's doing her daily chores.
you know, I ain't ever get to see her when I spend the night there, but she see her all the time. She hear her.
Well, there's two answers to that, and it depends on whether you're a spiritual person or you're a pragmatic person. If you're a spiritual person, then you may believe that the soul of the dearly departed is watching over you, visiting you, and you may derive some comfort from that. If you are a pragmatic person who's not really bent towards spiritual, you may think that is the coping mechanism of the person that is left behind. So it depends on what kind of person you are. Are you a spiritual person or are you a pragmatic, scientific person?
I've been class, I'm learning all kinds of stuff.
Like my mom sent me this video the other night of my grandpa, and this is crazy. No, my mom's moving out of her house. My grandpa just died. And there's the light bulb is not loose at all.
No, I'm laughing at that because that same thing happened to me.
Really?
Yep.
That's
The
crazy,
the
ain't it?
fan, the one light on the fan right after my father-in-law died.
My, like, she was
That's very strange to me. I'm actually a little freaked out about that because that's because I actually saw that in my own house.
Yeah. My little brother. Talking to my grandpa. There's nothing wrong with that light. It's not loose or anything. My mom sent me that and I was like,
It was like the last one. Give me a thumbs up.
and then it went extra bright. My mom said, and then it stopped.
Yeah, very strange.
Crazy.
Very strange because I've actually seen that happen. That's just I kind of figured it was, something electrical in my house. Now you got me questioning my whole life. Thanks. That's strange.
Yes.
So the biggest thing that I want to kind of wrap up this discussion with is the way you react to this, to a death event, is going to have a profound impact on everyone around you, the families, your coworker, everybody. So we do kind of have to get comfortable with this a little bit. You may not be comfortable with the dying process. You may not be comfortable with the afterlife, the question, all those existential questions that people have. But as far as your awareness and acceptance of this, you're going to have to get comfortable with that because part of healthcare is death, right? Even if you work in, so I went to school, in nursing school with a girl that did not, she would tell you right up front, I don't do death. That's not me. I don't like it. I don't want any part of it. This is my, and we all have our strengths and weaknesses, right? But that was her blind spot. She knew she wanted nothing to do with it. So she decided to go into mother baby unit, right? So she'd rather work on the life side of healthcare. Her very first day on the job, the child died during childbirth. So you need to understand that death is a part of healthcare and you can't escape it. You can't run from it because, anytime you have life, you will have death. I mean, they go together. You can't have one without the other. So even though you may not be comfortable with it, you have to find a way of accepting it and reconciling your own emotion to it. Because at the end of the day, we're not here for you. If you don't get comfortable with this, at least somewhat comfortable, you're not going to be effective when the people that matter need you.
Your reaction to whatever happens will hurt you or save you.
Absolutely. That is a very true statement.
Whatever you see happen.
Yep. Yeah, they can freak out all they want, but somebody has to be that calming presence, and they're looking for the people that are trained, right? If you're trained in freaking out, oh my gosh, that means this is a freak outable offense. I am justified in freaking out, and now there's no limits, right? So I'll give you a good example of this. I was a trauma nurse. I worked in ICU. I've seen a lot of things in my lifetime. Well, I cut my finger the other day. And when I cut my finger, the knife actually, it was in the, I had to pull it, use some force to pull it out to get it out of, and I immediately clamped down on it, right? All my pressure, because I don't, it's going to bleed. So I'm holding it like this, holding it hard. And I can't look at it because I know if I look at this, I am going to throw up or pass out, right? Now, remember, I have dealt with all kinds of trauma events. What made this different? It's me. It's me. So now I'm allowed to freak out, right? Sick patients have the right to act sick. So I'm allowed to freak out now. And my brain is not, yes, it went straight to training, hold pressure, get it underwater, make sure that, and I stood there for 30 minutes with this thing running underwater before I could let go. A knife. I mean,
You want the blood to fly.
Yes,
So why could it ever fly?
because I was cutting meat at the time. And I did not want those germs inside the wound. So I'm standing, but I couldn't let go of my finger because I didn't know. I was so scared. I didn't know if I was holding my finger on. I mean, I was scared. And I was that scared that I could not let go of my finger. I'm just standing with it underwater, just praying, oh my God, let it, oh my God, this is bad. Oh my God. And freaking out. Right. But remember that I'm allowed to freak out because I'm the patient. Now, if that had been my husband, I would have been perfectly calm. Well, because now I'm in that caregiver role. Right. So when it's happening to you, you can't be expected to be calm. But when you're the outsider coming in to help, you have to be calm. Okay. Does that make sense? So the way you react will save you or make this a totally, totally intolerable situation for everybody involved. Be calm. All right, so let me get your scores for 8 and 9. Okay, guys, can you put in the chat, put how many you missed for me? Oh, Freddie, I'm glad that you were able to get the audio working. Good. Okay. Do not know why my phone keeps turning on. Sure, remind me of your name. Okay. Go ahead. Right, I need 7, 8, and 9. Okay. Okay. Thank you very much. You are free to go. All right, Jashini. Paulette.
8, I missed 1, and 9, I missed none.
Thank you. Ty. Because Jordan. Brianna.
Chapter 7, I missed 2, 8, I got 100, and 9.
Very good. Ashanti.
8, I missed 1,
Thank you. Freddie got 100. Savannah. Thank you. Daniela. Tracy.
Chapter 8. Chapter 1.
Thank you. Did I call everybody? Let's see. Daniela. Very good. Thank you, Daniela. All right. So you only have chapter 10 to go. We graduate Wednesday. We're right there at the end. Right? Very close. Chapter 10 is the easiest chapter in the book. It's all on employability skills, things to make you attractive as a worker and employee. It talks about stress management, conflict resolution, those types of things. Super short chapter. I think it's only like 7 or 8 pages. Super, super easy. And we will go over some of that in class on Wednesday as well before I graduate you out. Because I do want to make sure that you are prepared to go out there and work as well as get past the test. But I got an email this week that I wanted to tell you guys about. Let me find it. I get a lot of emails. Okay. So, this is somebody who emailed me and she says, I spoke with my friend. She referred me to you. My name is Elaine and my doctor is looking for 1 to 2 CNAs to work in our office infusion center. So I told her to send me the information. She says they can send their resume and phone number to my cell number at, you guys ready? Anybody that's looking, 232-0116. Part-time or full-time, male or female, young or old. If they've graduated from your class, they are qualified. She was a graduate of our school years ago. Elaine. And if they prefer to send an email, her email is eRogerson, ROGERSON 55 @gmail.com. And she is a previous student of ours. So I told you guys, my name is going to open up a lot of doors out there. Her name is Elaine Rogerson, Rogerson. Her phone number is 232-0116. So if anybody's interested, there's a job opportunity for you. I also have some more posted on the board over there.
So I have a question.
Yes.
After graduation on Wednesday, do we still come in?
Yes, you can, if you look on the back of your ID badge,
Mhm.
in the bottom left corner, you'll see practice room. Says Mondays and Wednesdays from 1:30 until 4. And you can come in for a month after graduation. Unfortunately, no, I can't allow outsiders in just because of my insurance. My insurance company is pretty strict because you guys sign, when you registered, you signed those forms. So that puts you under my insurance. But anybody outside, I don't have those terms and conditions for. So what I tell students is make a Facebook group or a text group or something so that you guys can all keep in touch. That way, if you're coming in to practice, you can put put something out. Hey, I'll be in today at 1:30 to practice. Anybody want to join me? That way you've got somebody to practice on. Yeah, the mannequin, but there's some things that, it's hard to do on her. Yeah, blood pressure is a big one, but remember that's not on the state exam. Still need to learn it. Yep. All right. So any questions on what we've gone over so far? What we've learned? Any questions on what we've learned? No? Okay. How do we know what to do with each patient? Care plan. Okay. What happens if we can't follow the care plan for any reason? All right. Okay. Remember, I want you to remember this phrase, and this isn't on my skill rules, but I want you to remember this phrase. CNAs do routine tasks on stable patients according to the care plan. So if it's not a routine task that you've been trained to do, can you do it? No. If the patient isn't stable, can you do a task? No. So routine tasks on stable, this isn't a hard job, guys. They tell you what to do and you do it, right? And we don't expect any complications because you're not supposed to be thinking. Who does the thinking? The nurse. Those of you who are going on for nursing school, this is why nursing school takes so long, because you have to learn to answer all of the questions that could come your way. So once we have a care plan and we've read it and we know we have to do it, we're going to start the skill. Every skill begins with the opening. Every opening begins with a knock. Once we enter the room, and for the test, you don't have to wait for them to say come in. You just enter the room. You're going to address your patient by name. So for the test, everybody is Mr. or Mrs. Jones. And then you want to tell them 2 things about you. What are you telling them? Okay, so your name and title. And then you want to tell them why you're there. What are you there to do? So it doesn't matter how you tell the skill. You can read it right off the care plan if you want to. I am here to provide catheter care to a resident with a catheter. Or you can put it in your own words. I'm here to do catheter care. I'm here to clean your catheter. Once you've told them what you're going to do, though, you're going to get what? Consent or permission. Yes. Can you touch somebody without their consent? Even in healthcare, we can't do that? Okay, good. After you've gotten consent, you're going to close the curtain. Once you've touched that curtain, what's the next thing you'd like to do? Wash your hands, because the curtain is, yes, gross. I like it. Okay, now that we've gotten our hands clean, we took care of all the patient cooties. We have some clean hands. Now we can go get our clean supplies, but we need a place to put them. So we're going to go get a check. Should I get my checks when I get all of my other supplies? Okay, so I'm going to get it first, and then I'm going to put it on the table. Which side goes up? Absorbent side. Okay. Yep. All right. So once I get my checks on the table, I'll go get the rest of my supplies and put them on the table. While I'm getting those supplies, though, what should they not touch? My clothing. Yep. Part of those supplies might include gloves. How do I know when I need gloves? Okay. And okay, very good. So, yep, personal skin, private area, very good. If there's a possibility I might touch ooey gooey or personal skin or non-intact skin, I need gloves. If the answer is no to all of them, if they're fully clothed, holding on to all of their own body fluids and none of their skin is open, do I need gloves? No, because we're going to wash our hands before and after. Okay. Why shouldn't I just wear gloves for everything without thinking about it? Yeah, absolutely. We stop thinking about it. Cross-contamination on accident. So we need to be a little bit more aware than just wear gloves blindly. Has anybody had a sandwich after I went through that exercise with you?
I can't lie, I
Did you? Okay, I was hoping somebody would. Did you watch?
I really did, but I really couldn't see at the same time either.
Yeah, see, it'll make you more aware and you'll start watching now. And you'll be like, oh my gosh, they touch, oh. You'll be aware of it now, where before it wouldn't have made. Yep. Yep. It's funny. So if we're going to wear gloves, what's the first thing they should touch? The patient. And then when we're all done with gloves and we're going to remove them, how do we remove them? And then underneath. Very good. Very good. Okay. How do I know when I need a privacy blanket? Okay. So uncovered or undressed. Yep. So how do we use a privacy blanket? Do we just kind of snap it over them? Okay. Okay. So we're going to pull the sheet underneath. Okay. Let's see here. If we're going to use linens, and we've already found out they can't touch our uniform, right? What do we do with any extras we take? Okay, so they have to go into dirty linen. Linen should not touch the floor. Clean or dirty doesn't matter. They can't touch the floor. So hospital corners are going to be kind of important to keep those corners off the floor, right? When you're working with linens, don't have them too tight over the toes either. Make sure you're loosening that sheet so it doesn't push those feet down. Clean rolls toward me, dirty rolls away. And we use that for everything. Chucks, linens, doesn't matter. We're going to use that a lot. Clean rolls toward me, dirty rolls away. If I'm going to, speaking of rolling, if I'm going to roll the patient onto their side, what do I have to do first? Okay, so that after their turn, they're in the center of the bed. Now, are we turning them toward us or away from us? Away, because we have to remain behind the patient's behind. Yep, backside. Yep. So basically the patient will always be facing away from us. And can I just rely on side rails to keep the patient safe? No, they have to be in the middle of the bed. So time out real quick. What if during the test, I have to turn a patient onto their side and I realize that they're still a little, because when I look at them, they're still a little close to the edge of the bed. What should I do with that? Okay. Okay. I could do that, but for the test, I don't have another assistant. Okay, I can make a correction, but I can have them come back over, scoot them closer to me so that after the turn, they're in the middle. Don't ignore that. This happens a lot on the test is you turn a patient over, but they're still kind of close to the edge of the bed and you don't do anything about it. You just leave them there close to the edge of the bed. And I've seen it a lot of times. They have to be in the middle. They have to be in the middle. If they're not in the middle, do it again. Get them in the middle, scoot them back toward whatever you got to do, address it. Don't ignore it. Okay. The evaluators are looking for that. That's a checkpoint. They have to be in the middle. Okay. Now, if I'm going to wash it, so I've got the patient on their back, I'm going to wash her back, whatever. I'm going to wash something, right? What temperature should the water be? Not hot, not cold, just warm. But how do I know that it's warm?
That's with the patient.
Okay, so I'm going to check it and I'm going to have the patient check it. Where should I, what should I use to check it? My fingers? The back of my hand? The inside of my wrist. They're looking for that. Okay, inside of your wrist. And then have the patient check it. Whatever we wash, whatever we rinse, we dry. Don't get your surface wet, right? Make sure your surface is protected by something. If the sheets get wet during partial bed bath, you need to say something like the sheets are wet. I would change them. They're not going to make you change the bed, but you have to address it. Better yet, put a towel there so the sheets don't get wet and we don't have to worry about it, right? If we're going to use water, or I'm sorry, if we're going to use lotion, what do we have to do before we put the lotion on? Okay. What do we have to do after we put lotion on? Wipe it off. Okay. Now, all basins are cleaned the same way. For the test, we don't disinfect. We simply rinse, dry, and store, right? But when we're drying, do we use the same paper towel for the inside and the outside? Why? Cross-contamination. That's right. Very good. If we're going to put something away, can I touch that drawer unit? What do I need? Paper towel barrier. Very good. Very good. If the patient's feet hit the floor, we're going to talk about their shoes. Patients have to wear shoes. Slippers, socks are not enough. Very important. Very important on a lot of different levels. Pathogens, sharps, everything. Before you lift a patient to a standing position, their feet should be flat on the floor. How do I know a gait belt is snug enough? 4 fingers. Okay. And before I sit them down, what do they have to know? Okay. So they've got to be able to feel the chair with the back of their knees. Okay. Every skill ends the same way with the closing. The first 4 things on the closing we don't care about. Can anybody tell me what those are? Very good. Very good. After you've done all that, what do you want to do? Clean your hands. And then we're going to right. Yeah. Yeah, we're going to wash our hands again. I just ordered new banners, by the way. So the new banners have all, because like the closing doesn't have wash hand, so I redid the banners and I ordered them. They should be here probably within about 2 weeks, 2 to 3 weeks, I'm thinking. But it's pretty cool because when I redid the banners, I now have on the side of each big puzzle piece, all the little tiny, like the top parts of all of them. So you can see, all of them on each banner. So the new ones will be coming. These are actually, I sell these to instructors and they're being used in probably about 300 classrooms all over the country right now. Yeah. But it's a really cool way of visually seeing what you learned in class and how far you have to go. So like halfway through the program, we realized that we had already learned all of them. So we're just going to recycle those principles over and over. So it should have made the program pretty easy for you to learn. because you're hearing the same things over and over and over. Does that make sense? Good. Do you feel a little more confident now than you did at the beginning of class?
Yeah.
Okay, good. I know everybody's so nervous when you come in on day one. And then I finally get you comfortable and you leave. And then I get a whole new group that's like petrified on day one. All right, so let's, in that vein, let's go to page 57. So we know we have to read the care plan to know what to do with each patient. This care plan tells us to provide the following range of motion exercise to the resident's right hip, knee, and ankle. Flexion extension. Now, if you remember, flexion extension was an up-down motion. You guys remember that? Up, down? Okay, so for this skill, we're just going to make the hip go up and down and make the ankle go up and down. And we're going to do that 3 times each because that's what our recipe calls for. But the neat thing about this particular skill is that you're going to exercise both the hip and the knee together. One exercise gets both joints. So if I bend my knee like I'm going to climb stairs, notice my knee is bent, but so is my hip. So when somebody's laying down, this is going to look like you're bringing their knee toward their chest and back down to the bed. We're only going to go as far as the patient is comfortable. So some people can bend the knee all the way to the chest and back to the bed. That's awesome. Some people will not be able to bend that far, and that's okay. We're only going to bend it as far as the patient is comfortable. So how do we know when the patient is uncomfortable? Okay, asking. But what else could you watch for?
Facial expression.
Okay, facial expression, wincing or grimacing, grunting, resistance, feeling, resistance. They're not moving as, or they may actually make noises. So we want to pay attention to what our patients are trying to tell us with words and with other signs, because we only want to go to the point that they're comfortable. Now, each time we're going to go all the way back to our starting point so we get that full range of motion. And you want to support at 2 points, so under the knee and under the heel as we lift and go back to the bed. You don't just want to grab over the ankle and do something like this. You want to support from below. We never go above. So like we're not the claw machine at Walmart. Okay. When you do this, it actually can, your fingertips can dig in, and that can cause bruising and tissue damage. So anytime we lift anything, we're going to lift from below with a flat palm. So if we're putting socks on a patient, we have to lift their foot to pull the heel up. We're going to go underneath to lift it. If we're lifting the arm to do range of motion, we're going to hold underneath. Okay, good. This is a super short skill. Super short skill. And that's like really stretching it. So I need a volunteer, somebody to come lay in the bed, and I will show you how this looks. Thank you, Freddie. I got your scores. All right, here we go. Yeah, I was going to say, can you get in the center? Good catch. Good catch. Here we go. Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? Fantastic. I need to do some exercises on your leg. Is that okay? I'm going to close your curtain. Let me go wash my hands and I'll be right back. So if I'm not 100% sure whether I'm supposed to be working on the right leg or the left leg, and I've washed my hands, should I ask her?
No.
So for the test, you can go back and read that care plan anytime you want to, even if you've washed your hands, you're in the middle of the skill, you can stop and go back and read that care plan. This care plan, I believe, says the right hip, knee, and ankle. Is that correct? Yeah. So this is the patient's right over here. So I'm going to lift the leg, bring it to the chest and back to the bed, but I'm going to tell her what I'm doing. It's more important that she knows than those evaluators. Can you turn that camera a little bit for me, please? Thank you. Oh, I did get my my unit that's going to auto pan. That's good. Unfortunately, the battery hasn't come yet. So I've got the unit and I've got the remote. I don't have the battery yet. So hopefully. All right, Miss Jones, I'm going to lift your leg up to your chest and back to the bed. We're going to do this 3 times. I need you to let me know if there's any pain or discomfort. I'll do all the work. Okay. So a hand under the knee and one under the heel. We're going to bend. Nope, just
Oh,
one.
this one.
Just one. We're going to go up and I'll do all the work. So just relax all the way back down. Feel okay? Any pain? We're going to go up all the way back down and one more up all the way back down. Good. Okay. So now I'm going to lift your foot off the bed so that your heel doesn't rub. And I'm going to bend your foot forward and back to your head like you're stepping on a gas pedal. We're going to do this 3 times and I'll do all the work. So forward and back. Relax for me. You feel that stretch? Forward and back. That's 2. Feel okay? Forward and back. That's 3. Good. Any pain or discomfort? Are you comfortable? Would you like a magazine before I go? Your environment is clean. Here's your call light right here. If you need anything at all, just press that button. I'm going to open the curtain. Everything looks good. Wash my hands. Think about the skill and make any corrections. Tell the evaluator my skill is done. Thank you. So as you can see, it only took me like 2 minutes to do that skill, not 4. Good. Questions? Thank you. You make a great cameraman. Perfect. All right, any questions on that? All right, so let's talk about catheter care. This is on page 114. Now, this skill tells us the care plan to provide catheter care with soap and water to a female resident with an indwelling urinary catheter. Clean the catheter tubing and perineal area only. So in order to understand this, I need to explain to you about a couple of different types of catheters and how they work. Okay, so this skill is focusing on an indwelling catheter, which means we're putting it in and we're leaving it there. Catheters can be left in place for up to 30 days. And if the patient still needs it after that, then we change it. And then that one stays in for up to 30 days. And then if they still need it, we'll take it out and put a new one in and it'll stay there up to 30 days.
So you keep cleaning the same one over and over?
Right. Because the catheter will stay in place up to 30 days, depending on how, what the patient needs, right? So a catheter is nothing more than a hollow tube. It's a straw. It's a flexible straw. Okay. If you remember, we talked about the normal urinary system last week. And I said there's 2 kidneys. They filter blood. The urine drips down tubes into a bladder. A valve at the bottom of the bladder holds it closed until you go pee. And then the valve opens, pee comes out, valve closes again. You guys remember that? Okay. When we put a catheter in, it has holes at the top. The top is closed just to make it easier to insert, right? But it's still a straw. So we put this up the tube that's already there, the urethra. The tunnel is already, we're not drilling, right? The tunnel is already there. So we put this up through the urethra and we go past that valve. You guys remember that valve at the bottom of the bladder? We go past that valve, and now this is inside the bladder. So any urine can go down those holes through the tube and out to the outside world. So all a catheter does is bypass that valve. That's all it does.
That is in the valve will not.
Right. This is kind of holding the valve open, but the tube is what's going to collect the urine. As long as the catheter fits snugly, you shouldn't have any urine come out around the tube, but it's got to fit snug. Okay. Now, this alone doesn't help anybody because when the patient moves, it's going to fall right out. There's nothing that holds it there, right? Alone. So when we put this up through the tube, past the valve into the bladder, we have to have a way of holding it there. So we inject a little bit of water into a balloon, and that balloon acts as a doorstop. Okay. Now, if I want to take that catheter out, I don't want that balloon inflated. So I would pull the water out, and now it can simply slide right out. That's all a catheter is. Now, if I don't need the catheter to stay in, if I just need to put it there to get a urine sample, and then I'm going to take it right back out, it's not going to stay. Remember, that balloon is only there to make it stay. Then I would use something like this. This is the same thing. It's just a different color and no balloon. We make it a different color so it's easy to tell apart. We color code them. This is called a Red Robinson or a straight cath. Has a couple of names. Okay. This is called a Foley cath or an indwelling cath. It stays. So Foleys stay. Red Robinsons are temporary, just to deflate the bladder.
These are for both genders.
Both genders. So remember that we're not drilling anything, right? The tube is already there. The urethra exists. And remember, it's got to be a snug fit. So this isn't like comfortable, but the hole is already there. So those of you with pierced ears, do you know what it feels like when you put an earring in? It doesn't really hurt, does it? Right? Because the hole is already there. But if you put an earring in that's maybe a little bit bigger or heavier than you normally wear, it's uncomfortable. You can feel it. Same concept. Okay. Now, how far you insert it is what's going to be different between male and female. Because if you remember, we talked about this last week. I said that the female urethra was only about as long as your pinky. So if we're putting a catheter in, we're only having to put in about that far. Now, males, this catheter has to go through the entire penile tissue and into the bladder. So it's going to have to be advanced a little bit further. Remember that the urethra is already there. It doesn't really matter whether you're putting it in this far or this far. It's the same process. Okay. And remember, it has to fit snug. So once we get the catheter in place, then if it's an indwelling, once we get the catheter inserted, and we know it's inserted because we get urine, right? Urine falls because now we're in the bladder. Urine goes through those holes into the catheter. We see urine. So once we get it in place, then we inflate that balloon to keep it there. And now it can handle a little bit of tugging because this is flexible. But if you pull too hard, it's going to come out, balloon and all. And now we've got something this big going through a tube that big, and that's going to cause some tearing and probably some pain and a little blood, right? Now imagine for a second what that's going to feel like for somebody to pee through that. It's going to sting and burn and be somewhat painful. So we want to try to prevent that. So the big thing is when a catheter is in place, don't pull on it. We want it taped to the thigh so it doesn't pull. But you also need to be aware of the bag, because this alone is just going to let urine go everywhere, right? This doesn't really accomplish anything other than make the patient incontinent. So this is going to attach to a bag of some sort. This just literally plugs in, but it plugs in tightly. So it takes a little bit of work. Now, if you remember what we talked about last week, I said that bladders are the ideal breeding ground for bacteria. You guys remember that? Okay. Well, when we put these two things together, it's really easy to touch the outside of the port or the inside of the catheter because you're trying to force them together. So usually nurses are the ones that put these two pieces together. CNAs can be trained to do that, but you've got to make sure that you are super clean when you do this. You'll have gloves on. You got to make sure those gloves didn't touch anything, because any bacteria that gets in here goes straight to the bladder, and that's a problem. So you can be trained to do this, but for the most part, most nurses are going to take care of this. Okay. So now we have a closed system. This end is in the bladder. The urine goes through the catheter, through the tubing, and into the bag. There's nowhere for bacteria to get in here once it's closed. But if you separate these two pieces, now the bacteria have an entry point. And if you empty this bag using the port at the bottom, now the bacteria have an entry port. So we have to be really, really careful when we're emptying the bag not to let bacteria in. So we don't want this port to touch anything. Not your gloves, not the cup, not the chucks, not the bed, nothing. We take it out, we slide the valve to the side because it's a T valve. If you look through here, you can see that it's closed. You see that it's closed. If I open it, when you look through, now you can see that it's open, which means that urine can come out now. So I'm going to position this over the cup, let the urine flow out. And as soon as the urine is done, we're going to close it back up, and then we'll put it back into its house without touching anything. So I don't want to, do something like this. I want to very carefully, very specifically tuck it right into its house. You have to make sure the valve is closed. Good? Makes sense? This is one system. Catheters inside the patient. The urine bag and tubing collect the urine, and the only place for bacteria to enter is this port, or if you separate these two pieces. And bacteria in the system is bad. Good. Questions? For the test, you are assigned to clean the catheter and the skin around the catheter using soap and water. That's what our care plan says. So when we're cleaning this, we have to be careful because remember, this is inside the patient, right? So we don't want to pull on the catheter and pull it out because that's not going to put up with a whole lot of pressure. So when you're cleaning the catheter, you want to hold it where it exits the body. And that way, when you're wiping, it's not pulling inside. You're holding it stationary. Good. Questions so far? Okay. These do get pulled out. patients do pull them out because it's an irritation. It doesn't belong. It doesn't feel right. So especially your dementia patients will pull them out. And when they pull them out, you know, these bubbles will probably cause a little bit of bleeding because, you know, tube this big, bubble that big, you're going to have some tearing. But sometimes it's not the tissue that tears, it's the bubble. When a catheter gets pulled out, you need to save this whole thing, the whole thing. Put it in a bag in the bathroom. Don't just, you know, dump it in a trash can somewhere. Put it in a bag in the bathroom, and the nurse has to come take a look at it. Now, if I look at this catheter and this is what I see, the whole thing is intact, the bubble is still there, everything looks good, that's fine. I can work with that. That's a me problem. But if I look at this catheter and it looks like this after it's been pulled out, that bubble burst. Now, I've got to figure out, did any pieces get left behind? So I've got to look at this and make sure all the edges line up. And if they don't, that means that a piece is left in the patient. That is not a me problem. That is a surgeon problem. Do you understand the difference? So if a catheter gets pulled out, you need to save it, put it in a place where the nurse can look at it and let her know right away. Because anytime there's injury, there's always swelling. Always. So if we have swelling in this area, this is probably not an area I want swelling, right? So if we've got swelling in the area, I've only got about 45 minutes to figure out whether I need another catheter. Now, if I can make do without one, I'm going to make do without one. But if the patient can't go without a catheter, I don't have a choice. I got to put one in. And if there's already swelling in place, I may not be able to get it in. So this is one of those situations where if the patient pulls the catheter out, you need to let the nurse know sooner rather than later. Don't go on break, feed somebody lunch, and at the end of shift, oh, by the way, Mr. McGillicuddy pulled his catheter out. It's in the bathroom. I can't do anything about that now. It's too late. So this is one of those things you want to tell them sooner rather than later. Good. Now, I will tell you that as bad as patients are at pulling these things out, we are the biggest culprits. CNAs pull out more catheters than patients do. And there's a couple of different ways that this happens. This tubing, this is inside the patient. This tubing is long to give the patient an opportunity to move around freely. But if the tubing is coiled near the floor, your feet can get all tangled up in that tubing and accidentally pull it out. So tubing should not be coiled near the floor. It should be on the bed. That keeps it safe from you, basically. Okay. If you're going to turn a patient onto their side, you should always look to see, do they have a catheter? And you need the bag on the same side as the patient is turning to. If the bag is on the other side of the bed and you're turning the patient away from you and away from the bag, you can pull this out. If you're transferring a patient from a bed to a wheelchair, you should always see, is there anything attached to the patient? Because that catheter will stay in the bed when you get the patient out. Yes.
Get accused of pulling their bird off.
Oh gosh. We also do this when we're ambulating patients a lot. You stand the patient up, start walking, and pop, it comes right out. So as bad as patients are, we are way worse. So as CNAs, it really is super important that anytime you're going to move a patient, you look to see what is attached to the patient. Do they have a catheter? And make sure it moves with you. Now, catheter bags should never be higher than the patient's hips, right? Urine should always be a one-way trip. Urine should never be recycled. If you pull this bag up above the level of the patient's hips, yeah, It's recycled urine going in, and it's going to take whatever bacteria is in the system with it. And I've seen this walking down a hospital corridor. I have seen a urine bag hanging from an IV pole. That's pretty gross. So be careful, never put this above the level of the hips. Good? Questions? Okay, infection control is the name of the game when it comes to catheters. We never want to inject bacteria into the system. Catheter acquired infections kill about 2,500 people a year. This is serious. So we don't use a catheter unless we absolutely positively have to have one. We don't use it for convenience. And the reason is, remember I told you in your system, you have a couple of bouncers, couple white blood cells in your urethra, that when a bacteria happens to stumble in, they get rid of it really quick. Well, the problem is when you have a catheter, it provides a secret tunnel that those bacteria can go up and hide from the white blood cells. There's no white blood cells that can get to them. They're inside the tunnel. And this is a real problem because that one bacteria, by the way, bacteria don't need little boy bacteria, little girl bacteria to have baby bacteria. It doesn't work like that. Bacteria just need the right enzymes and proteins, and then they zip themselves in half and make a copy. So one bacteria can quickly turn into two. One human will never turn into two. But bacteria have this great ability to be able to do that. So one bacteria can turn into two. Feed them, they turn into 4, then 8, then 16, then 32, then 64, then 128, and on and on and on. So it doesn't take long to realize that one bacteria in this bag is going to multiply quickly and start to climb because they're out of room. And they climb, and now they get fresh urine, which is an all-you-can-eat buffet, and they really multiply. And now there's 100,000 of them, and they keep climbing. And then they get into the catheter, and now we've blocked out light. It's warm, it's dark, and now we get those enzymes that we're looking for to really ramp up production. So by the time they jump out these holes into the bladder, it's not 1 or 2 bacteria that's invading, it's 1 or 2 trillion. And it's overwhelming. And within 30 minutes, your patient can go from totally fine to totally sick. And you're like, what happened? That makes no sense. It's because the bacteria was allowed to multiply in this whole system without being discovered. So they invade all at once. This can be catastrophic for your patient. And it's why it's critical that no bacteria is allowed in this bag. The catheters are generally cleaned once a shift. Usually your care plan may say once a day, depending on the needs of the patient. But once a shift is pretty standard. Okay. Now, this bag works really well if we're in a hospital type setting. It holds a lot of urine. We're only going to empty it once a shift. So we need something that's going to hold a lot, right? So this works well in a clinical setting. But if I'm going to Walmart, I probably don't want to carry a suitcase of urine around with me. That's, makes people stare, brings attention, and it's kind of a little bit gross. So if I'm going to Walmart, I'm not going to use a big bag like this. I would have a leg bag. So if you turn 2 pages, 1 page. What page is that, Tracy? 116. You can see what a leg bag looks like at the top of the page. This is a little more discreet. It's about this big, and it actually attaches the inside of your thigh or your calf with elastic bands or Velcro bands. And it just allows you to inconspicuously have a catheter, but still be able to interact with society. There are people right now in Walmart with a catheter, and you have absolutely no idea. In our community, we have probably about 100 people with an indwelling catheter that are living their best life. And you wouldn't know it. There's no need for you to know it because it's hidden. Okay. So to recap, there's two different types of catheters. There's one that we put in, inflate the bulb, and it stays in for up to 30 days. Nurses change them out. Nurses put them in, nurses take them out. You can be trained to do that if your job needs it, but that's a whole different ballgame. Okay. Remember, you can be trained to do anything a nurse does under delegation, but it has to be routine and it has to be on a stable patient. The other type of catheter is a straight cath or a Red Robinson. This is simply inserted to get a quick urine sample and take it out right away. It doesn't stay in. Two different types of catheters. You have a couple different types of bags. Big bags for long periods, small bags for mobile applications. But there's one more type of catheter that I need to tell you about, and that is called an external catheter. Now, this thing has a lot of different names. It is called an external catheter, a condom catheter, or a Texas catheter. You'll hear it all three ways. This goes on like a catheter, as the name, or like a condom, as the name implies. And it's only for males. So you see it there in the middle of the first column on page 116. This is only used for males. And it's external. So it's going to roll over the shaft of the penis. It's sticky, so it stays in place. And it just diverts urine away from the body and into a bag. So this can be a good solution for an incontinent male patient that we don't want urine against the skin for a long period. If they have some sort of a bed sore or something like that, this is a good solution. But it has its own issues because it's held in place with sticky stuff, right? That can irritate the skin. But the port on the very top of it where the urine is going to go out, it's going to allow urine, adult urine, to have prolonged contact with the tip of the penis. Remember that adult urine is acidic. So these have to be removed every 3 days and cleaned thoroughly, preferably left open to air to dry out a little bit before a new catheter is applied. This condom casts require a significant amount of skin care. Okay. Otherwise, you end up with lots of problems. And I have seen some very serious problems from these.
So they don't use these unless they have to.
They're used a lot more frequently than you would think because they're used for convenience. But you just, and they're a good solution as long as you're aware of their limitations and that you make sure that the skin is really well protected. Okay. Good. Questions? All right. These are sometimes used by diehard sports fans that don't want to get up in the middle of the game and go to the bathroom. Yep. Yep. They're called stadium bags.
Oh, Lord. That is crazy.
Yeah. Yeah. Kind of crazy. Yeah, I'm not that committed to anything. All right. So any questions on catheters or drainage bags? All right. So I'm going to show you these two videos back to back. They are two separate skills for the exam. So you would have catheter care as a skill. You would have drainage bag as a skill. They may show up on the same care plan set, but they may not. Okay. So they are two separate skills. But I am going to show you the videos back to back. Generally speaking, if you're doing catheter care, you're going to be emptying the bag at the same time. So in a clinical setting, they do go together. But for the test, remember they're graded separately. So you're going to do your opening, catheter care, closing, opening, drain, empty the drainage bag, closing. Okay. So if you turn to page 1, I don't have my book. Probably 117. Yeah. Yeah. If you read the care plan at the top of the page, it says empty the resident's urinary drainage bag into a graduate container and measure and record the urinary output in mLs or cc's on the documentation form. So this is what we're going to use to measure urine. This is a triangular graduate container. That's why it's called it, because it's a triangle shape. It has graduated markings on it, so you can measure stuff. So it's called a triangular graduate container. Everybody calls this a urine measuring or urine measuring cup. But its technical name is. This has both ounces and cc's on it. This is exactly what you would get for the state exam. These are the cups they use to measure the urine. So which side do you think you're going to be using to measure for the test? cc's. If you use the ounces side, you will fail, because the care plan specifically tells us yes. Okay. So remember that we don't want the port of the bag to touch the inside of this cup. So you've got to be really, really careful there. Of course, we're going to have gloves on because we're working with urine. So gloves are going to be important. But this, remember, we can't lift the bag above the level of the patient's hips. So this is going to go on the floor. And then we're going to empty the urine from the bag into this. But we don't just want a urine cup on the floor. We need to put something under it. What's something we can put under it? A barrier. So we're going to put a barrier on the floor. We're going to get the cup and put it on the barrier, empty the urine into the cup without touching anything. And then we're going to close the port, put it back, and then we're going to take this over to the bathroom to measure it. Okay, so we can't carry an open container of urine anywhere, but we have that barrier that's under it. So we're going to wrap the barrier around this, take it over to the bathroom, and put it on the lid of the toilet. Now, it's very specific how this has to be measured. And all three of these are on the same checkpoint line. So you've got to get all three to get any. So it has to be measured on a barrier, on a flat surface, at eye level. So we've got our barrier because it's wrapped around the cup when we take it over there. On a flat surface means it's going to be on the toilet lid. And then at eye level means that you actually have to get down to measure it at eye level. Good. Questions? Okay, on the video, I actually bring the camera down so you can see where the urine is. For the test, this is going to be yellow colored water. So they do tint it yellow specifically to make it easy to read. If it were clear water, it'd be really hard to read here. So they do tint it yellow for you to make it easier to read and make it feel a little bit more like urine. Now, where is this going to be emptied when I'm done measuring it? In the toilet. I'm going to rinse the cup because we rinse everything. And where do I dump the rinse water? In the toilet too. And then we're going to dry it and put it away like we do everything else. And then we're going to do our closing. After our closing, then we'll document. So you've got to remember that number for a long time. At least a whole minute, which is a long time. So good. Okay, I'm going to pass all of this around So you guys can see it, feel it, play with it, touch it, whatever. I find it's easier for you guys to do catheter care if you actually understand what is inside the patient, how this whole thing works. Otherwise, you're so afraid of it that you don't want to touch anything, you know? So that's why I give you these to really kind of play around with so you can get comfortable with it. Make sure you look at the catheter that's broken so you can see it. I came down yesterday and put the new cameras up and everything. So you can see the mount up there. I had to take them down because the cords that we're using, they have to be run up in the ceiling for all these cameras and everything. And I'm not quite done setting all this up yet. So you guys won't get to see the multi-camera setup, but the next class will. And I'm actually going to be live streaming the next class in my online course. So if for some reason you don't get to test before my next class starts in September, you'll be able, because all of you have access to that online course, you'll be able to go in there and join in live through Zoom the next class and see the multi-camera and all of it, because it's going to be open to the public. Yeah. So you guys were kind of my dress rehearsal. We had to work out a lot of kinks along the way, but we're getting there. I'm super excited. It's all starting to come together. But it was a fun day yesterday, setting it all up and getting it all working and seeing how it's going to look and work. And it's pretty cool. All right. So while you guys are looking at that, I'm going to put these videos on. Like I said, I'm going to play them one right after the other. And this finishes up all of our skills. This is it. These are the last two. And then we'll take a break. There it is. Oh, there we go. Okay. I'm going to close the curtain, wash my hands, get my supplies, and I'll be right back. Okay, my friends, I'm going to gather my supplies.
I'll start out with a barrier that provides clean place to put my supplies. And we're going to get 4 washcloths. A towel. A tuck. A privacy blanket. And now I'll gather my basin and stove. And a set of gloves. Alright, as soon as I get some water, I'll be right back. Okay, would you like to check the water temperature and make sure it's okay? It's good? Good. I'll place the washcloth in there to stay warm. I'm going to cover you with a privacy blanket. This is going to help protect your privacy and keep you warm while we do this stuff. And I'm going to pull your sheet down so back my knees. Okay, Michelle, I'm going to place this pad underneath you. This is going to help keep your bed dry while we do this skill. First, I'll roll it toward me. Place it on the bed. And then I'll put my gloves on. All right, Michelle, can you scoot toward me, please? Thank you. And can you roll onto your left side? 1, 2, 3. Thank you. Be very careful, making sure that the catheter tubing rolls with the patient and the head is pulled off. I'm going to unroll the checks underneath the patient's hip and have the patient come back onto their back, making sure that they don't lay on the catheter tubing. This Jeff, can you stick to the middle of the bed, please? Thank you. Your third, can you stick for me? Thank you. And roll up onto your right side. 1, 2, 3. And now I can unroll the cup. Come back to that. Come on back, please. Let's stick to the middle of the bed. Thank you very much. Okay, now I'm going to start cleaning the catheter. I'm going to roll your gown up inside the blanket. I will be exposing you, but we'll make this as brief as possible. Please let me know if you're uncomfortable. As I roll the gown in the blanket, I want to make sure that I don't grab the catheter, that we don't cause any unnecessary pulling or stress on the catheter. And now we'll cover her thighs with a towel. This exposes only the area that we're working on. I'm going to take the first washcloth and then it out. And apply soap to 4 leaves. 1, 2, 3, 4. Now I'm going to clean your catheter. I'm going to hold the catheter where it exits the body, wrap the washcloth around, and wipe away from the body. Fold that leaf over. I'm going to hold it, wrap the washcloth around, and wipe away from the body. That's 2. We're going to do this 2 more times. Away from the body. 3. And the last one. 4. I'll set this washcloth aside. Whenever we wash, we must rinse. So I'll wring this washcloth out, and we'll use it to rinse that catheter the same way we wash. I'm going to fold it where it exits the body, wrap the washcloth around, and wipe away from the body. We'll do this 4 times. 2, 3, and 4. Set this aside. Now we'll dry the catheter. Now we're going to do peri-peel. We'll take a washcloth out of the basin, bring it out really well. also 5 corners. 1, 2, 3, 4, and the back side is 5. Okay, now I'm going to clean the peri area. I'm going to lift the catheter up out of the way with my pinky and hold the labia open while I clean down the center with the first loop. I'll be going top to bottom. And then we'll remove the washcloth and fold that loop over. Now I'm going to clean down one side of the labia, top to bottom, fold that loop over. Clean down the other side of the labia, top to bottom, fold that loop over. I'm going to clean the skin fold between the groin and the leg, fold that loop over, and clean the other skin fold between the groin and the leg, and then set that washcloth aside. I'm going to take the final washcloth and wring it out really well, and we're going to rinse all of those areas the same way that we washed them. So I'll fold that catheter out of the way and spread the labia open, clean down the center, top to bottom, fold that loop over, clean down one side of the labia, fold that loop over, rinse down the other side of the labia, fold that loop over. We're going to rinse the skin fold, fold that loop over, and the other skin fold. Set that aside. Now we'll dry gently by patting dry top to bottom, and then removing the towel. Then I'm going to cover you back up. I'll unroll that blanket, which will replace the gown over the patient. I'm going to make sure that the catheter and the tubing is coiled on the bed, not near the floor, and not where the patient is laying on it, making sure it's not clean. Ms. Jones, I'll be right back. I need to dispose of for supplies. The towels and washcloths will be placed in dirty linen. The basin is going to be cleaned the way we clean everything else. We'll return the basin to the floor, and on the way we'll pick up the stove. Open the door with a paper towel. Return the basin to the storage area. Now I'll dispose of my paper towel. Okay, Ms. Jones, I need to remove the cup from under you. Can I get your ID, please? Thank you. And can I get your rollers on your left side? 1, 2, 3. Thank you. I'll roll this soiled cup toward the patient and tuck it under her hip. Come on back and toes. And scoot back to the middle, making sure the patient is not laying on that catheter tubing. Okay, Ms. Jones, can you skip toward me again, please? Thank you. And roll up on your right side. And I'm going to remove that cup from the back. Okay, you can scoot back to the middle. Thank you. This is going to be thrown away. Okay, Ms. Jones, let me just look at the catheter one last time. Make sure that the catheter tubing is coiled on the bed, that the catheter is not on the floor. Everything looks good. I'm going to remove the cup from the table. And we're going to throw this away. And then I'll remove my gloves. We'll throw those away. Okay, Ms. Jones, I'll pull your sheet up now. And I'll remove the blanket as I do so, rolling it into a ball. You put this in dirty linen. Okay, Ms. Jones, here's the call light. If you need anything, just let me know. Are you comfortable? Can I get you anything while I'm here like that, please? I'm just going to open your curtain and wash my hands. After washing my hands, I'll think about the steps to my skill, make any corrections that need to be made, and then tell the evaluator my skill is done. My name is Patty. Today, how are you? Great. I need to empty your urinary drainage bag. Is that okay? Okay, I'm going to close the curtain, wash my hands, get my supplies, and I'll be right back. Put the skill on the barrier, which I'll place on the floor under the drainage bag. I'm going to use a set of gloves. Going to need a triangular graduate container. I want to set the catheter pin to make sure that it's put on the bed and the patient is relying on it, and it's not pink, but also that it's not hanging near the floor where somebody might get their foot tangled up in the spread or accidentally get the catheter out. This catheter looks like it's in the appropriate position. So now remove the port from its protective sleeve on the back. Sliding it out to the side will open the port. We can now position this open port over the graduated container and tilt the bag slightly to the side to allow the contents to drain into the graduated container. While doing so, we want to be careful not to allow that port to touch any other surface. Once the urine bag has been emptied, we'll slide the port back to the side to close it and very carefully insert it back into its protective sleeve. We want to make sure that the bag is hanging on a non-movable part of the bed and it's not touching the port. We can now fold the cup over the graduate container for safe and secure transport to the patient's house. Once we're on the patient's bathroom, we're going to set the graduate container down on a barrier on a flat surface and position it so that we can read it. We need to be at our level, and we're going to round nearest line, either up or down. You can see that the urine container is nearest to the mark of 425, so the amount document is 425 milliliters of BC. Once we've measured it on a barrier on a flat surface at eye level, we can now empty the urinary graduate container. We'll throw the barrier away, open up the toilet, and we're going to dump the contents of the graduate container into the toilet. Now we're going to rinse the graduate container. We'll deposit the rinse water into the toilet as well. Now we can clean. After dumping the rinse water into the toilet, we'll set it down. Use a paper towel to pick it up. Paper towel to dry on the outside. Paper towel to dry on the inside. Part this, and then one to the floor. We're going to place the graduate container in the lock door. Close the door with the paper towel. Okay, now I'll throw the paper towel away and remove my gloves. Good way as well. Thank you very much, Vincent. Is there anything else I can do for you while I'm here? An action perhaps? You have your call out here. If you need anything at all, please feel free to let me know. I'm going to open your curtain, wash my hands, and document my skill. Thank you. I'll document on the different outputs the evaluator gives me. I'm going to document the time of output, the type of output is the zero, the amount of output is CC, and my initial. After documenting all the steps of my skill, make the correction, and then output of the skill.
All right, any questions? Questions? No? All right, well, that concludes all skills. It's all done. So go ahead and take your break. When you get back, the rest of the class is just practice.
Yeah, it's super.
Kevin yet? Or no?
I don't think so,
wanna
girl.
I told everybody I graduated on Wednesday.
Well, I went in the wrong door, but there was nobody over there, so.
You been coming here for 7 weeks, and you don't know the door.
I told you. Here. Is that for me? For the record. She's writing it in my book. Can't forget it.
Then again, you might not bring your book.
I always bring my book. Just in case. Cause I never know if I'm gonna have a group or a one-on-one.
I'm always doing that.
And if you ever wanna practice,
Okay.
I'll practice wherever.
Okay.
You're not doing shit. And if
I
I
still
need
wanna
to
come to practice. You can't practice, you know?
I asked Donald to practice with. And I,
It's like a walking.
I tried to practice on my.
With the man, you didn't work with us.
It's like a walking.
because you don't wanna be my patient. He don't wanna be my patient.
I'm trying to figure out, 'cause
Create a-
he told me, he's trying to sit
Like a chat.
Yeah.
To get all the numbers and.
right. But take my number. Right, well, right there you go.
We might as well. Just write it to the,
Contact book.
look here, we'll just pass it around.
Or I could just make it right.
I'm gonna put mine on there in case somebody wants to take a picture of all the numbers.
Right, I'll take it.
Go to the top and just add everybody's number.
I never knew.
You gotta like put them in like individually, but it like put the comma after every number you put in.
Oh, okay. What's your number?
929-323-8467. And you can put 4 of that, or you can put 2. Anything.
It's not written.
I said to Donald the other one, I said, what kind of beef is that? Who's gonna be? I said, oh, no, were you talking?
I know Diva, yeah.
But you walked up in there like you were Diva.
I know.
You walked up in there like she owns it. She went down the hall, she's like, what's going on?
I know, and
heel.
And his being in. Yeah, but I was feeling outside his room yesterday because nobody came after me. Nobody came until 7 o'clock. So he already had me aggravated. I didn't care who had that whole way. I was weak. So as I'm standing there, I see a black boy coming with a little 2-year-old. Both was cute. So I'm already looking. But he comes in the rest of it. I said, oh, you Lorenzo family?
Right?
He said, yeah, that's my uncle. So now I walk in with him. Mind you, I was leaving.
Okay.
Right, I walk back in there.
How you doing?
So I said, oh, Lorenzo, your nephew's here. So at first he didn't recognize him.
I'm listening.
He didn't recognize him at first, right? So then he looks at him and he said, oh, nephew. I'm like, what's up? So his nephew talking to him. So he said, yeah, he said, she's in our family too. She got married then. The nephew said, you in our family? I said, no, we'll pay your uncle no mind.
Right?
So I said, Lorenzo, I'm leaving. I see you on Tuesday. He said, oh, you going to the army?
I love some of his conversations.
I said, Lorenzo, I'm not going to no damn army. I'm going home. He's like, oh, don't leave me, baby.
Right?
I'm like, all right, give me a hug. Even though I didn't really want to hug him because he gave me that.
Yeah.
I
But
thought-
you still care about him.
I thought what's his name, Harold,
Uh-huh.
his wife was there,
Oh, yeah?
but they had the door closed, right? But I'm in Lorenzo's room, cursing up a storm because he had me that aggravated. So at the same time, I'm like, oh, good shit.
Right.
Because I don't know how much you there. CNA there, telling them, well, I'm gonna let you fall. Because that's what I said. All right, I keep telling you not to get up. I'm gonna let you get up and you're gonna fall.
Right,
But I ain't supposed to say that.
right.
All right. No, that is so aggravating.
Yeah,
For CNA?
yeah. I've got like 3 job interviews already.
That's,
Who are you interviewing with?
Sugar Mill Manor.
Yeah.
And then Homestead, and then I have one for Kimmel.
Especially if they don't get these done. I work on that one. She goes, I can't work with this.
Group chat.
I work with my sister.
They pay, the working shopping price, they pay, when you use like $19 an hour, you get like a maximum of like 15 cases. Like they poured over to my neighbor room, I think that's.
See, I don't want to see they, that is stressful. I don't want no more vacation. Cause I'll be dying with this one.
It's
Oh
working.
my God.
It's all
I
right.
didn't have it. Okay.
Yeah, my mom said she had to go in, she worked at the store, she's senior living. My mom said she had to go in there the other day, she was.
No, it's, don't get me wrong, it's nice in there, but it's just, no, it's nice, it's just,
For the old people.
a lot of people there that don't belong,
Mhm.
they belong somewhere else. Like, for real, for real.
There's no fun in this making laugh.
We don't even know, we don't wanna know what it is, Tracy.
Really don't.
Right. Going for the whole day.
It's not really. Like, in the middle, we have like.
Oh, you got the whole everything?
Yeah, just take a picture.
That's what I did.
Alright, let's create some chat.
I was like, you can do that.
I took a picture, I still can't find it.
You miss it?
I know, right?
We're used to making, you don't know.
I'll make it. Okay.
I can do it. I mean, I have.
I'll make it.
Well, I got a whole bunch of little sisters that can come in.
Okay, does anybody have any questions for me?
Nope.
No? Okay, no problem. No, I already passed the rest. You're good. Off the clock. Okay, I'll just take these. All right, so the rest of the class is practice. You guys are free to break up in groups and practice.
Question is,
Oops.
are you going to give us a written practice test?
If you turn in your book to page 142, we actually usually talk about that next week. Or I'm sorry, next class, not next week. You'll be out next week. You go to page 142. Yes, Ty, I'll be happy to do that. If you go to page 142, you'll see a practice test. This is very similar to the state exam. I know I don't bring your attention to this until the last day usually, because I want you to do all the reading before you take the practice test. But yes, we give you one of those as well. And on my website, foryourcna.com, I have a practice test on there too that gives feedback. Okay. One of the things that I'm working on that I worked on this weekend is on my main website, foryourcna.com. I have a new way that I'm showing the videos. So if you've been on my website up until now, you had to click on each one to go to a page to see the video. Well, now I actually have it on a playlist, all of the videos. So let me, let's see here. So on your phone, this would probably be the easiest way to do it. I might. You go to foryourcna.com/videos, videos,
What'd you say?
foryourcna.com/videos. You'll see that I have 3 playlists there. The first one is skills review videos. Below the video is the care plan, and then another tab that shows the steps, where I have the steps written out. Below that are the animated lessons. So everything is on one page. All of my videos are on one page. It also, the last grouping are all of my lives from this year. So the live sessions that I do on Thursday, they're all there for you as well at the bottom. I don't have my cord to plug it into the TV, so I can't show you. But go to foryourcna.com/videos. And that should make it easy to review all of the videos that we've gone over. Plus it lists the steps right below the skills too. Please remember to bring your blue book back to class on Wednesday. We will take a class photo. It does go on Facebook. I don't tag anybody in it, but you can share it or tag yourself. You will need to return the blue book, and I'm going to give you a folder, graduation folder, that has, a certificate that just shows that you went here. And then some additional information on resources you still have available, how to find employers, that type of thing. Okay. I know. It does. Remember, I said that on the first day, it's going to go super fast. Yeah. All right. And the rest of class is yours to practice.
Yes.
Ty asked if we could turn the camera over to that area so that he can kind of participate in practice as well by viewing.
So I took everybody's stuff.
Okay.
Here. Ready?
Okay.
Get, name.
Hopefully we can get them on Wednesday. Unfortunately, I can't give them out. So hopefully they'll, look to get involved. That's actually a pretty nice picture there. Very good.
I was scared you went practice.
And I am here to help, but it's best to practice in groups of 3. So one person is the patient, one person should be doing the skill, you're the CNA. The third person should have the book and be reading along. And if the CNA gets stuck, prompt them, tell them what the next step is, so that everybody learns in that scenario. If I give you all the answers, it doesn't help you learn, right? So I'm over here, I'm listening. And if you have a question, you need to ask me. And if I notice you're doing something really wrong, I'll tell you. But I want you to kind of do it and feel your way through it, figure it out. That way, the three people plus everybody watching kind of learns a little bit more effectively than me just giving you the answers. Okay. So I am available. I don't stare at you because people get like really nervous when I'm, staring at them. So I don't stare at you. I'm kind of hidden over here in my little cubby, but I am watching.
Every now and then, because I just feel here like Patty. I'm sorry, I do the opening and I'm here seeing Patty.
Yep, it does. So we should start a petition. All CNAs should be Patty from now on, right?
You feel like. Oh, yeah, the restoration, right?
Yeah, that's a mannequin skill. It's above your bed. Okay, somebody do a range of motion. So do range of motion.
Can you say it again?
No. Is that my TV talking to me?
I found more than one device with the name TV. Please give them unique names, then run discovery again. Or create a group if you want to control them simultaneously.
Yeah, I still haven't figured this whole thing out. I got to turn that voice thing off. That's fine. Range of movement is fine. Well, but you're supposed to touch the curtain.
But I wash my hands.
Okay. So correction, I would have closed the curtain before I washed my hands. It's that simple. Yeah, you can't give up. Keep going.
Take your right leg, hold it up, and I'm gonna get to the chest. Are you okay? That's it.
Okay, support under the knee too. Support under the knee. There you go. One more. Good.
Okay, that's fine. Yeah. I'm gonna wash my hands. and I'll be back. Okay, Mr. Jones, are you comfortable? Do you need anything else from me? Everything's all right? Can you practice the music? And I'll be back. How was that?
It was very good. But you have to say your skill is done.
Oh, yeah. My skill is done. That was hard. Yeah, it is.
Once you've done it once or twice, though, it's going to feel so much more natural.
Right.
You're not being watched, not being graded.
Right.
It just kind of rolls off your tongue when I'm going in, it just rolls right out.
And they think you know what you're doing. So, you know, you don't have that pressure. But
If I was starting right now, imagine doing that.
well, that's just it, though. You have to, if you're nervous, you have to practice that much more before you go to the test, because you don't want, can you imagine you're paying $155, you waited for test day, you get in there, and then you do that, you touch the curtain after you washed your hands, and then you try to quit. So you've just paid all that money for nothing. So this is why you want to make these mistakes here. And you want to learn from them, because when you go to the test, now you'll remember that and you're less likely to make that mistake during the test. So those of you who are nervous about testing, you need to practice even more before you go test to make it natural. Guys, the first time I started teaching in front of a group of people, strangers that I did not know, my voice was like 3 octaves higher. I sounded like Minnie Mouse. I was talking way too fast. I was nervous. I was making all kinds of mistakes because I was nervous, right? Everybody gets nervous when you're being watched. But when you do I look nervous up there now? Okay. How did I get from Minnie Mouse to here? Yeah, just yeah. I mean, I'm not even really thinking when I'm up there teaching you, because I've done this so many times. I'm on autopilot, So the only way to get there, to get on autopilot, so you don't have to think during the test, is to do it over and over and over and over again. And then when you get to the test, you're going to realize, oh, wow, this is really easy. I don't know what I was stressing about.
Right.
When I was in the that hurt. This much about oil and gas windows. So part of my job was meeting with attorneys and meeting with businesses. And I would get so nervous when I got nervous. My tongue was a different picture.
Right, and I already stutter.
I said everything probably the wrong way.
Right.
And probably take a Tylenol, one Tylenol, before you meet with an attorney, and it will refine so you can perform that. So first 3 or 4 meetings with an attorney, I would take one thing, and I was actually calmer. Still a little nervous, but still calmer. But I done so much better when I was calm. Then the more I learned, I didn't need that. I was walking in like I did the attorney building, like that was my building. I'm here to let's get it done.
Yeah, you gotta develop a strategy to overcome your lack of comfort, your discomfort. Yeah, and you'll find it. A year from now, you're gonna be like, this is all old hat.
Right? Still kind of nervous right now.
So let me ask you this, what's the worst thing that can happen?
Fail.
Okay. All right. So if you fail, are you any worse off than you are right now?
No.
Okay. So failure does not mean catastrophic damage, right? Yeah, you'll be out a little bit of money because you'll have to pay to retest, but it's not like somebody's going to throw you into off of a volcano, right? Right? So Jaws isn't going to come and eat you. So if you fail, you're no worse off than you are right now. It's not like you can never work anywhere ever forever, right? It just means that you're in the same place. You didn't get to advance, but you're not moving backwards either. So take that pressure off of yourself. It doesn't impact you if you don't pass. You just don't move ahead yet. That's it. That's it. There's no penalty. There's no impact. There's no nothing. You're no worse off than you are right now. Right? So if you kind of think about it in those terms, it's like, well, okay, so this just helps me advance. But if I don't do it, I stay where I'm at. It's not like you have to go backwards. Okay. Yeah. Right. Yes. Yep. Yep.
Can you like reapply to like take the test again?
You
Take both of them.
nope, just the part that you failed. Just the part that you failed. And they usually give the skills first, usually, not always. If they have, because remember, you're there with other people testing, right? So if they have 3 people that day that are just retesting written, they're going to do the written test first to get everybody the written test done so those 3 people can leave. But most of the time, the written, not a lot of people fail the written. It's pretty easy. Okay. Most of the time the skills are done first. So even if you bomb the skills, they're not going to tell you. They're not going to give you your report. You have no idea because they want you to take the written. That way, at least you're leaving with a win of some sort. They want you to pass. It's not, and that's the other thing with these evaluators. Everybody thinks the evaluators are intentionally trying to trip them up or fail them, or that's not the case. In fact, with the evaluators, if their pass rate is too low, it flags them, and then the supervisor has to come watch them evaluate. So then they get graded. Because you can't have an evaluator out there rogue, just failing everybody because they're grumpy. That's not fair. This is a state exam. I mean, this is serious. So they're monitored as well. They're not trying to trip you up. They're not trying to make things difficult for you. They're not trying to fail you. They know that we need you out there. So as long as you can show that you can do the skill safely, that you understand patient rights, that infection control is important to you, there's not much there that's going to fail you. All of the principles that we've learned along the way. So if you are dressing a patient and you don't have a privacy blanket on them, right? If you just strip them and they're laying in the bed naked, how do you think the patient's going to feel?
Very uncomfortable.
Yeah, vulnerable, cold, uncomfortable. So that would certainly be something that we wouldn't want you doing that in a real life setting. So that would not let you pass. And that's why we have the If a patient is uncovered or undressed, we need a privacy blanket, right? So not using a privacy blanket is going to be important from the patient's point of view. That's how the whole test is graded. When you miss a step, it's not you missing a step. It's what effect does that have on the patient? So, and a lot of people would come to me and say, well, I don't understand. I only missed one thing on the test and I failed and I don't understand why. I only missed one thing. But who does that put the focus on? It should be on the patient. So if you can make that change, and I know it sounds simple, but it's not. If you can make that change in your brain, turn it around. The test is nothing to do with you. Nothing. It is not about you at all. It's about the patient, the person in the bed. That's who they're looking at. That's what they're focusing on. And if you can focus on the same thing, man, that test becomes super easy. And you won't forget those important points because it wouldn't even dawn on you not to use a privacy blanket because that's my aunt in the bed and I don't want her exposed, you know, so it becomes easy to remember these steps. Plus I've, you know, beat them into you. I have. I mean, you've heard me say the same things over and over and over. Do you remember on day one, I told you you had all the information you needed to pass the test? I meant it. Let me come around so you guys can see me. You literally had all of the tools at your disposal on day one. On day one. It's all about the patient. Indirect care counts. You know, how we interact with the patient. The opening, the closing. Guys, the opening and the closing, that takes up more than half of the checkpoints of every single skill. That's why we learn it first. And then we say it again, over and over and over and over again. So when you look at the checkpoints of any skill that you have to do, so if you look here, when you look at these checkpoints, right? And this is an activity I actually want to start having students do. I want you to take one of these and I want you to, the checkpoints, and I want you to look at these banners and I want you to see what checkpoint is covered by a banner. And you'll see that almost all of these checkpoints are on that back wall. You know what to do. You've seen it. You've done it. You're familiar with it. But it's the way that I teach that makes it easy to remember it. Okay. So it wouldn't dawn on you not to use a privacy blanket. It wouldn't dawn on you to put a gait belt on and not check to see if it's tight enough, 4 fingers. Right? So yeah, almost all of those checkpoints are covered on a banner. That's how I developed the program. This is all me. I created these, the puzzle pieces. They're basic nursing principles. But it's, you know, I actually did it on a cruise ship. Yeah, I was on a cruise ship and I was creating a video, an animated video, because I do a lot of work on ships. So I was making an animated video and it dawned on me that, man, I'm saying the same things over and over and over and over and over again. So isn't there a way to shorten that? You know, can't I just like say one thing and it encompass all of those steps? And that's how these things were born. It took me probably about 6 months to get it all worked out, but it makes it so easy to learn. So easy, and it's repeatable. But you have the skills you need. You just have to get over your own anxiety. That's hard. You have my sympathy. I know it's hard.
Me too, my whole life.
Very few wake up in the morning and go, woo, I get tested today, right? Everybody has test anxiety. It's not, some people are a little bit worse than others, but that's not a unique condition. I've always been an awesome test taker. I can take a test on a subject I know nothing about and pass the test. And the reason is I'm able to pick up on context clues. So test taking, it's a skill like any other skill. A written test is not difficult to pass if you can pay attention to context clues. But even still, I have anxiety when I know I'm being tested, right? Now I know I can pass the test, but because I'm being tested, I still have anxiety. I actually became a realtor when we sold our last house because I didn't want to pay commission. I took the test. Well, I took the class. I took the test. I passed it. I became a realtor. Now, that's a hard test. It's a lot of law. So I took 5 weeks out of my life, learned how to become a real estate agent, took the test, passed it, and became a realtor to sell my own house. So I didn't have to pay commission. I still was a nervous wreck. Now, this wasn't for a job. This wasn't for anything, this is just so I can save myself a little bit of money, right? So it didn't have any bearing on anything, but I still was nervous going in to take that test. I get it. Testing makes you nervous. Everybody gets nervous. Now, there's some people that get more, they'll be throwing up in the parking lot because they're so nervous. There's some people that are like that, but everybody has test anxiety. But do you know who else knows that? The evaluators. They know that. They know that you are a nervous wreck. So if you are like, oh my God, your first skill, you're shaking and you're like, oh my gosh, I forgot. I touch a privacy card. They're going to tell you, just stop, breathe in, breathe out. And they're not going to let you not. They're actually going to say, look at me, breathe in. Come on, breathe in, breathe out. Okay. You good? Okay. Go ahead and begin. They understand you are nervous because every other person that's come in that room has been nervous. You're not unique here. They will try to help you cut through all that noise to refocus. By your second skill, you'll be much better. But that first initial one, when they hand you that care plan and you read it, your brain will go blank and you will forget your own name. So do you remember what I said the very first day? As long as you know your name, I can build from there. Okay. And I meant that. So for the test, you just have to remember your name. The rest will come to you because I will be in your head. Just remember your name. And a lot of people, what you do, a lot of people do at the test. It's amazing how many people say, I'm Patty. And they say, yeah, I know what videos you watched. There's a reason we're coming up on 26 million views. Everybody out there thinks they're Patty. But it's okay. It's all right. Okay. Good. That's my pep talk for today. Everybody should try something. At least wash your hands if you haven't done that. Good. Look how much you guys have learned.
These airplanes in the white notebook, are these like the same ones they give you? Or
Yes.
These are the investing ones?
Yep.
He said no. Now you see it.
Come on, if you guys practice while I'm in here, I can at least help you. I don't know when I've heard that that may change next week, but I don't know for sure. Yeah, they're removing a lot of COVID restrictions in the last couple of days, so.
I do it. The one math, question on the test, is that common knowledge?
It will either be a conversion question where you have to convert ounces to cc's, or an addition question where you add up the amount of intake for the day. That's it. Those are that's the only type of math. It's math that's related to CNA. Right.
No, it's just, multiply that. You know how when we serve them breakfast, and you have the paper, and it tells you, oh, they have juice, say 8 ounces, whatever, so when you multiply that by 30, that gives you 50. And then you actually have the total, you add up all the numbers together. And then that's the total intake. You add it all together.
Just remember, anybody that wants the flashcards, they're still available for $14.99 until after Wednesday.
You get that from you?
From the register next door.
Well, we're pulling out the paper for the test, right?
Yep,
Say certification option eligibility.
E3 Challenger.
that or
What?
bed? I want
Yep. So a bed alarm is something that the Blue Book talked a little bit about, restraint alternatives, but it's designed to alert us when a patient gets out of bed. So if they're unsafe walking on their own, a staff member can go assist them. It's not designed to keep them in bed. It's just to let us know when they're out so that we can help make them safe. So it's considered a restraint alternative. 'Cause it doesn't interfere with the patient. No, no, it doesn't interfere with the patient's ability to move about as they desire.
What is our website again for, to make an appointment for the, background check?
Oh, it's Daontis, DAONTIS.com. Yes, if you don't already have one, yes. Yes.
Do you know if I need to watch things for this one? Or is
No,
it-
you have to register first.
Okay.
Um, somebody did tell me recently that they were able to walk in, but basically they have to have all of your information so that when you check in, they can verify it. So I don't know if they walked in but had to go out to their car and put their information in the, well, I don't know. But I'm not real. Yeah, yeah, because that's how they're going to verify your information when you go in.
Not right next door.
Absolutely. Yeah, you don't have to, during practice time, you guys are free to move about.
They're asking for like, both of them are asking for like a number.
Okay, yeah, the ORI. So you need the Florida services. Hold on, I did a whole video on it, but okay. ORI. Oops. Mm. Okay, there you go. So guys, the ORI number when you're registering with Deontis, I forgot to tell you this. I'm glad she brought it up. You're going to want to write this down. I'll wait till everybody gets ready. EDOH 0380Z. Sure. Yeah, absolutely. Absolutely.
past Wednesday, I cannot find the link for the Zoom call.
I'll look on the website and see. I know Yashini had the same problem today.
I
He
found,
emailed me.
there was a link for today's and Wednesday's, it wasn't for last week.
If it's after 9 a.m., I think it like becomes invisible.
Oh, okay.
So I've got to somehow get in there and fix that, but that's on my list of things to do.
Okay.
Yeah, I don't know why it disappears like after I start. It shouldn't, it should stay active. So sorry about that. Yep, the first one. Yep,
Okay, thank
click on the first one and then you're gonna put that ORI number in there.
Is it all capitals or is it?
Doesn't matter how you put it in. Nah. EDOH. Oh, yeah. E like Edward, D like dolphin, O like Oscar, H like hotel, 0380 Z. You're welcome. You guys have any questions? Okay.
There's more than 60 written questions, correct?
No, it's 60.
If they text you directly, they'll usually offer them. I would say that after you get a bit, it's not bad. Yeah, stuff like that, so you- but, so, yeah.
Yeah, it's for instance, really, at this point, I just need a job.
There's also another one, another assisted living in Homosassa. Not sure why that TV keeps coming on.
Yeah, that's the one.
Um, Oak, it's like if you get, you know where, the, Publix is at 98.
Yes.
Okay, it's the road kind of behind Publix.
Oh, yeah, that.
Yeah, Royal Dalton or something like that. Yeah. Yeah. I know they're hiring too.
Yeah, you know what I mean? It's straight in. You don't have to take a picture. right. Have a good day.
You have a fantastic day, guys. See you Wednesday for graduation.